and I am going to get started. So here we are, guys. It is September 27th. It's another Friday. This is the Florida EMS webinar for myself and Tanner Smita. We bring on amazing guests who write essentially amazing papers. So what we do is we crawl the literature, and then we randomly email people who we've never met before, and we say, "Pretty please, will you come and talk about your paper?" And today is going to be a great one. We've gotten so much feedback already, and she hasn't even started speaking yet. Many people are on Twitter commenting and LinkedIn. This is a topic that's of interest to many of us, and we always look towards the folks up in Seattle to do really impressive research to help guide our profession forward. Um, and Dr. Bonnie Snyder used to be up in Seattle, and many of her colleagues are on here today. And now she's a second year resident in emergency medicine at Cincinnati. And so, without any further ado, Bonnie, thank you for joining us. Please make any further introductions and take it away.
Absolutely. Thank you so much for having me. So yeah, I am Bonnie Snyder. I'm here to talk about my paper, which we titled The Association of Small Adult Ventilation Bags with Return of Spontaneous Circulation in Out of Hospital Cardiac Arrest. So a little bit more about me. I was actually born and raised in a small town called Wasilla, Alaska, where I was briefly a ground paramedic in a 911 system prior to completing my undergrad there in the University of Alaska Anchorage and joining the University of Washington School of Medicine for medical school. Between my first and second year, I had the amazing privilege of joining the Division of EMS team to start working on this research project, which continued throughout my medical school. I graduated in June of 2023 and then joined the University of Washington University of Cincinnati emergency medicine residency, where I get to pretend that I'm still a paramedic on our helicopter. Um, so we will get into the paper. This was not a funded project, but we do disclose that one of our collaborators, Rob Walker, is employed as a biomedical engineer at Stryker Physio Control. This QR code is directly to our published paper, so in case you want to follow along as we walk through it. So to get started, we know that excess minute ventilation can adversely affect hemodynamics in cardiac arrest by increasing intrathoracic pressure, decreasing venous return, and negatively impacting cardiac output. We also know that cardiac or carbon dioxide is a major regulator of cerebral blood flow, and that hyperventilation can cause vasoconstriction, which can worsen secondary brain injury. Additionally, nearly half of all out-of-hospital cardiac arrest survivors who survive to 48 hours develop ARDS, which we also know is worsened by large tidal volumes. So with all of this in mind, the team at Seattle Fire Department changed from a large adult ventilation bag, which has a total volume of 1685 milliliters and an expected one-handed delivery of around 700, to the small adult bag, which has a total volume of 1,000 milliliters and is expected to deliver around 450 mLs per one-handed squeeze. This change was made in July of 2017 and is used for all patients in the system, but we were specifically looking at adults with cardiac arrest. So we set out to assess the relationship between the small bag use and the incidence of ROSC in OHCA. And we hypothesized that the rates of ROSC would increase after we made this change. So some of you might be familiar with the very impressive cardiac arrest registry that the Medic One and Division of EMS team manages. All cardiac arrests treated by Seattle Fire Department are prospectively recorded using Stryker LifePak 15 cardiac monitors, as well as a black box audio recording device. These data are then input into a post-review software, which is demonstrated here. We were specifically looking at our end-tidal waveforms and the associated ventilation extrapolated through this software, but also incorporated into this registry are data from the 911 call, the pre-hospital care record, and hospital records. And these are all kind of input and reviewed by the SFD quality improvement team. So we defined our study period as 2015 to 2021. During this time, 3,252 patients were treated for cardiac arrest. We figured that there would be some time of overlap as we transitioned to the small bag from the large bag. So we excluded about 3 months when we weren't sure exactly which bag was in service. After this, we made a number of exclusions. We excluded children. We were specifically looking at patients that had an advanced airway, meaning an I-gel or intubation, and had care provided by paramedics. So if you only had BLS care, this is sort of a population of patients that may have just gotten like a single AED shock and had ROSC. If you had a DNR, if your care was provided by a different agency and not Seattle Fire, you were all excluded. If you got a crike, if your airway was placed during spontaneous circulation while you had a pulse, we were not as interested in that specific population of patients. Um, and then just sort of for our capnography data, if you did not have any capnography data, you were kind of fell out of this group. And then also if you um, were had a pulse throughout the time a paramedic was caring for you, you didn't have kind of any of our time periods of interest, so you fell out as well. This gave us 1,994 patients with 48,600 minutes of data. There was some data that was not analyzable from an end-tidal perspective, and then there was about 15,000 minutes where these patients had a pulse, and we were not specifically looking at those time periods. So that left us with 26,921 minutes of cardiac arrest data to look at. This was split into our cohorts based off of time frame, like we talked about earlier. So we had about 2.5 years in the large bag cohort, 663 patients, and then just over 4 years in the small bag cohort, and understandably about double the amount of patients in minutes. So demographics of our study population, on average, everyone was 62 years old. About a third of them were female, almost 2/3 arrested at home. Of the patients that arrested prior to EMS arrival, 63% of them received bystander CPR. Of all patients, 21% had a shockable rhythm initially. And on average, our case length for how long these patients were resuscitated was 34 minutes. These characteristics were statistically similar between cohorts, although within the small bag cohort, more people died at home, and also more of them received bystander CPR. So what did we find? Very unexpectedly, we found that the rates of ROSC at the end of EMS care were less in our small bag cohort as compared with our large bag cohort. So this is sort of a dense table, but you can see we had 40% of all patients had ROSC at the end of EMS care, which was defined as either they were declared dead in the field or they crossed the threshold into an emergency department. And only 33% of the small bag cohort had ROSC at the end of EMS care. That was a statistically significant difference. This just shows that our rhythms were a similar distribution between patient groups. And while survival was not a primary focus of this study, they did show similar trends for survival to admission, discharge, and neurologic outcome. Excuse me. So because this is a cohort study, we calculated an odds ratio. This is basically the 0.74 number is comparing the two groups and is basically saying that those patients in the small bag cohort as compared to the large bag cohort have on average a 26% reduction in the odds that they've achieved ROSC at the end of EMS care. We calculated a 95% confidence interval, which is kind of how likely that number is to be accurate, and found it to be 0.6 to 0.9. Because this number does not cross 1, it is felt to be statistically significant. This is a forest plot, which just demonstrates this sorry, I didn't mention was this is our adjusted odds ratio. Our unadjusted odds ratio is very, very similar and had a similar confidence interval, but we wanted to make sure we were accounting for any potential differences between these two groups. So particularly things about the groups, characteristics about the groups that would affect their odds of achieving ROSC. So those specifically were age, their sex, was their arrest witnessed, did they receive bystander CPR, and what was their initial rhythm. So all things that are known to affect their ability to get ROSC. And after adjusting for potential differences between the two groups for all of those things, the difference stood. This just shows kind of by those differences, the relative weight of change for favoring the large bag versus favoring the small bag. So when we got this answer, we were perplexed. We ran the data multiple times. We wanted to make sure we hadn't first made a mistake, that our data was accurate. And then we set out to think about pretty hard as to why this might be, despite our hypothesis. So we thought, could this just be because we are including COVID? We know that our healthcare system, both pre-hospitally and in the hospital, as well as just our day-to-day life, changed incredibly. So the first thing we did was just first exclude all of the patients after COVID was identified in King County. So that was defined as February 27th, 2020. We took all the patients out after that, and the difference was almost exactly the same. Our odds ratio was 0.75 with a similar confidence interval that did not cross one and was still statistically significant. We then thought, is there something different about this cohort that we haven't accounted or adjusted for? So we added a number of variables that we felt would be meaningful to patient outcome to our adjustment analysis. So in addition to the ones that I mentioned before, we added the etiology of their arrest by upseen characteristics, whether they arrested in public, how long it took from their 911 call to the initiation of CPR by EMS, as well as the placement of advanced airway by EMS, and then also their total epinephrine dose. When we added all of these variables to the adjustment, the association remained the same or similar. It moved slightly, but our odds ratio was still 0.79, although our confidence interval did widen to 0.99. But was still statistically significant. We then thought, is this just something to do with change over time? We reviewed whether or not there had been any significant cardiac arrest protocol changes, which there hadn't within our study period. But is there just something temporal about this data because it covers many, many years? And this is sort of a more granular demonstration of that. Each of these dots represent the proportion of ROSC for all our patients by month. And we compared kind of the slopes of these two lines, and this was not statistically different. So moving on to our secondary outcomes, we wanted to look at both ventilation rate as well as end-tidal values during cardiac arrest. This is a density kind of heat map, which consumed many, probably hundreds of hours of my time, and something I'm still quite proud of. So on the left, we are showing each 30-second interval of ventilation that we assessed, and we're given a ventilation rate. This is moving kind of forward in time, with time 0 being the placement of an advanced airway. Again, iGel or ET tube, although there's a very vast majority of ET tube within this group. The comparison between ventilation rates between groups was similar, not any statistical difference there between 11.9 and 12. These are kind of confidence intervals through time. On the right, we actually placed each value of end-tidal data for every single ventilation, which it was somewhere around, I think, 280,000 ventilations that we looked at. And those are displayed here for each entitled value, again, showing kind of our density here, and then moving forward in time. This was a statistically significant difference of 33.2 in the large bag cohort. Again, this is intra-arrest data as compared to 36.9 millimeters of mercury in the small bag cohort. So again, this is a dense table, which is published in our paper, but just some things to call out here that, like I said, no difference in ventilation rate. There was a reduction in our end-tidal value. When we look at what periods of time fell within the recommended kind of guideline range of 9 to 11, being a little bit more liberal than about 10 that the AHA gives us, we did have a slight increase in adherence to that guideline in our small bag cohort. Although this is kind of a very large amount of data, so it's going to show a more significant difference than may be clinically relevant. We also found that hyperventilation with a rate greater than 18 was relatively rare and similar between cohorts, so around 11 and 10% respectively between the large and the small bag cohorts. One other thing I'd like to point out is just that this high performance teams is able to achieve impressively high entitles during arrest, even for our patients who are in asystole. So 34 and 37, similar to our shockable rhythms. Okay, so what does all of this mean? Kind of to summarize, we, from a ventilation standpoint, we feel like we're quite good at sticking to those guidelines. It was interesting for me to kind of dive into these international CPR guidelines, like the ILCOR as well as the AHA, which have very vague recommendations. Again, the phrasing is it may be reasonable to deliver about 10 breaths per minute. And these are all weak recommendations, which have limited supporting evidence based on like low quality evidence, largely derived from healthy patients. So it's kind of hard to extrapolate that to our very sick population of cardiac arrest patients. One limitation to our study is that we could not directly measure tidal volumes with the equipment that we have. However, because we had the same ventilation rate between cohorts and had a lower end-tidal value in the small bag cohort, it does suggest that maybe we did deliver a lower minute ventilation to confer that change. One thing I wonder about, which again, we did not have available within our study characteristics, is patient height and size and how this could be affecting our outcomes. When you look at tidal volumes recommended based off of predicted body weight, based off of height, you only have to be taller than 5'11" as a man to need a tidal volume of greater than 450 to give us that 6 mLs per kg. And maybe this is why on that chorus plot, our female group, which is a much smaller proportion of our total population, tended to favor better toward the small bag. Some other limitations that we had in our study is that we know that both cardiac arrest care as well as abstraction and data review into our registry has some inherent variation over time, and that research done in a single EMS agency may have low generalizability. To conclude, the question that everyone has asked, I think, since this paper has been published is, should this or will this change practice? And I think we're quite hesitant to have this drive practice changes. I think really more so than anything, it just revealed that there are more questions than answers when it comes to pre-hospital ventilation, particularly in cardiac arrest, and that really we need a high quality randomized control trial to answer this question. So I would like to thank the amazing staff of the Seattle Fire Department, as well as my team at the Division of EMS. Being a resident now, I think it has given me a lot of perspective of just how amazing it was that I got to be a part of this and do this work as a medical student. So thank you so much, Dr. Sarah and Dr. Counts, for your mentorship, and I would be happy to take any questions.
Wow, what an amazing presentation! Very clear, very succinct, and just a great research project. Before I hand it over to Tanner, I just wanted to clarify just for everyone in the crowd, and then Marvel, we'll get to you in a little bit because I know that you have some data here too. But just to clarify, you were not using pediatric bags, you're using the small adult, about 1,000 cc's, correct? And because there are people probably on this call who have moved to the pediatric bag, right? And
Sure.
to my knowledge, I haven't seen any data on that. And so my first question for you is, what is, and maybe this is better for Mike or Catherine, or um, what is SFD doing today? Number one. And then the second question I have for you, and you had alluded to it in the limitations, which is, are we at the point where we should be looking at ventilation volume on every breath? I know that that's a possibility, and I learned that from the Lethbridge folks who happen to use Zoll, and they actually look at um, every tidal volume for every cardiac arrest, and they see the differences when those volumes get too high or too low. So I'll start with those two questions. I'll pass it off to Tanner, and then we'll go to Marv.
Yeah, thank you. So our manufacturer that we have used as Seattle Fire is the Mercury Medical Ventilation Bag. I think some differences exist within the marketing for these bags, that this is labeled as a small adult ventilation bag. That is the name of it. And those are the volumes that the engineers publish, like with the product brochure. But I do know that, there are pediatric bags that have similar volumes that are labeled as pediatric bags. So a little bit hard to parse out there. I'll defer to you and Dr. Sarah and Dr. Counts for what Seattle is doing now.
Sure, I can dive in. So Bonnie, terrific job on the project overall, and especially leveling up in your Tableau skills. And so we did not change anything based on these results. Point one. Point two, we're currently doing a randomized trial of ventilation during cardiac arrest in Seattle and the rest of King County, where we're comparing ventilation by our first responding EMT crews using bag mask ventilation with a two-handed mask seal versus iGel. And this is, as part of that project, there's a sub-study that Counts has been spending many hours on, involving the EOLife device to measure ventilation volume. That is in a research mode where it is in a black box mode, so there's no feedback to the crews. And we're learning how to interpret the data flow from that, which is good, but not perfect. So I think we have a bit of a natural experiment, because in Seattle, we're using small adult bags. In some parts of the rest of King County, they use large adult bags, and other ones use small adult bags. So maybe with a difference in difference type design, we can tease this out a little bit more to see if there's actually a relationship between ventilation volume and outcome.
Well, I had a feeling that oh, go ahead, Bonnie. Yeah.
Oh, I just want to speak to your question about like real-time feedback and whether that should move towards standard of care. I think this is maybe just like a personal opinion, but coming from like a rural place that provides EMS, I think having more data is unlikely to be harmful and could often be helpful in like high performing systems, but that across American EMS, the implementation of that is going to be difficult, and I think hard to generalize recommendations across such a wide variety of resources, where some places still don't even have like waveform capnography, that having real-time tidal volume is probably an unrealistic expectation currently, but definitely something interesting that is becoming more frequent.
Yeah, that's a great comment, and I'm so happy to hear that you guys are leading the charge and trying to figure this out with EOLife, and we're looking forward to that data set. Tanner, let me bring you in, and then I'm bringing the Marv Wayne after you. Go ahead, Tanner.
Sure. Yeah, first of all, I'd just like to say thank you so much to you and your team of authors for doing this study. I think it's one of the best before and after studies I've ever read. I think all the buzz that's been created around it is deserved. I think, for a couple reasons, it highlights the importance of ventilation during cardiac arrest, which I think has been a neglected area of research for a long time. And I think it also serves as kind of a cautionary tale, right? For any of us, if we're going to modify and the boundaries of care for any disease process, right, we need to continually monitor outcomes and be kind of self-critical. So I had a few comments and questions. So I'll give you all those, and then you can respond to whatever ones you want, and then we can move on. I know a lot of people have comments and questions. So first of all, again, we've mentioned this a couple of times, right? This is a single system, right? It's really high performing, high proportion of patients with endotracheal intubation. Looking at the adherence to guidelines for ventilation rate, right? High performing, even when we're looking at the large bag cohort. So the first thing I did was, given kind of how long over the period of time that this study was conducted, I looked for kind of other areas of practice change or evidence for that within the paper. And so I found two that I wanted to give you an opportunity to comment on. So the first one was the increase in supraglottic airway placement from the large bag to the small bag cohorts. So early on, it was like 1 to 2% in that large bag cohort, and I believe in the small bag cohort, about 8% of patients received iGels, which I think is definitely something that could impact the end-tidal CO2 values that we're seeing, especially with concerns about kind of leak around the cuff of the iGel device during CPR. I think that could definitely impact the volumes that are delivered and the end-tidal CO2 values that we're seeing. Another kind of area of practice change that I believe I found was in the supplemental figures. You described the proportion of patients who received Lucas CPR. So in 2015, it was like 33% of patients, 2016, 44%. The beginning of 2017, it was 30%. And then it looks like the Lucas device was not used from 2017 onwards. So 0% of patients received the Lucas during that kind of small bag cohort. So I wondered if you had any comments about kind of these changes in practice.
Yeah, the Lucas was before my time, so I'll defer to the rest of the team for that. I can say for the iGel, that really what drove the majority of the change was that after COVID, during a period of kind of uncertainty about aerosolized generating procedures, there was a temporal change in how frequently iGel was being placed in 2020 and 2021. That is kind of further specified in the supplement, and I think accounts for the difference. Overall, still a low proportion, but did increase in that setting. So prior to that, as far as within the small bag cohort in 2017, 18, and 19, had very similar rates. And so I think we would have kind of caught whatever that difference is when we excluded for COVID. So I can say that about iGel.
Okay.
And then with regard to the Lucas, Tanner, these were just patients who had any Lucas CPR, and our guideline is to only put the Lucas on during that time. The only patients that got Lucas were those who were getting transported with ongoing CPR, which is a small fraction of patients, in order to get an intervention in the receiving hospital, which we learned subsequently really doesn't work in our hands, so we stopped doing that. And then we don't have any Lucas cases.
All right, thank you. So in terms of the mechanism here, I know this paper really focused on kind of ventilation, right? Hypercapnia, end-tidal CO2 values. But also, you mentioned in the paper that you have available to you SpO2 waveform data as well as impedance data. And so I think the question is, there's some previous data that suggests that, especially looking at post-ROSC SpO2 values, there's a nearly linear relationship between about 70% and 100% when we're looking at rearrest and mortality. And There was another observational study published that looked at actual lung inflation measured by impedance and found that that was associated with better survival. So with all these different kind of data streams that are related to ventilation during cardiac arrest, I wondered if you had any further plans to study these values and these variables in relation to large versus small bag usage.
I'm out of the loop on the Seattle
That's
Medic
a
one
counts question.
plan, sadly.
So we
Count
don't
your
have
on.
any, yeah, so for the large bag cohort, we don't have any historical data streams for that cohort that we analyze the data that mostly the data that we have, and the use of SpO2 as a waveform has increased over time for our cardiac arrest cohort. Dr. Sayre kind of hinted at a natural experiment because we do have some King County agencies that will have the big bags versus the smaller bags. And then the EO-Life, again, not a perfect measure, but it does give us some degree of kind of volumes. So we're getting an additional data stream. We're paying more attention to this kind of in real time, prospectively. So definitively more to come, but it's also just trying to get the data and clean the data. And as analytic processes become cleaner and easier, and we did all of this in Stata, which for those of you that use analytic technologies know that's probably the dumbest choice we could have made. We've since teamed up with people that do waveform analytics and are using more powerful softwares like MATLAB and Python, et cetera. So we're getting better at this.
Excellent. All right, we're going to stay in the Northwest for a moment and go to Bellingham, Washington, to Dr. Marv Wayne. Marv.
Yeah, hi. First of all, you all don't have any idea how difficult doing a study like this is. In counts, you are amazing. I will always say that. And, it's always interesting. But so we are the bastard cousins to the north. We're about 110 miles north of Seattle. And we really appreciate their impetus they create for us to do things, whereas we create some of our own. So we went to the small bag probably a year or a year and a half later in Seattle on our own, motivated by the same question of hyperventilation. Logistics are a little different. We covered 2,500 square miles, 250,000 people, and a lot of our initial work is by BLS with iGel. So all our BLS providers are qualified to do iGel. So that changes the picture a little bit. It also made it very much easier with the big bag, we felt, to hyperventilate. So when we went to the smaller bag, we also added a couple of things. We added a manometer to the bag, feeling that it would decrease the motivation to over ventilate in the sense of pressure. And we added a timing light, hoping that that would decrease the hyperventilation, because usually the person that's squeezing the bag is the least trained person whose catecholamine level is higher than the patient's catecholamine level after we've given them epi. So that's always a consideration. So motivated by the paper and by the great potential of maybe we're doing harm, maybe we're doing good, we went back and I looked at our data in the ensuing years. Now, I don't have the data interpretation level that Seattle, we aren't collecting everything that they have. We do need to, and we're working toward it. And Counts has been amazing in helping our data people get up to the level that we need to be. We did not see a negative effect of the bag change. We looked at it before COVID when we had just started it, through COVID, which was really all jumping all over the place, and then since. And our ROSC, our go-home survival with good neurologic outcomes have pretty much remained the same. What we don't know, and beautifully brought up during this thing, what we don't know is what we don't know. We don't know what's the actual volumes that we're giving. We don't know if we are still, even with the smaller bag, able to hyperventilate. And we don't know, again, related to things like the question that Tanner brought up of the iGel seal. We use iGel. And our endotracheal intubation numbers related to iGel use in our system is much higher right now for iGel. So we're migrating that once the patient gets ROSC before transport, they're going to get the intubation. Some get it during the resuscitation if it appears that we are not adequately ventilating the patient. So there's a lot of open areas to fill in here. And Bonnie, you and the folks down there, Mike, and of course Counts, really deserve a lot of credit. So I think what you've said, though, is something that we are still saying. We think the smaller bag is a better overall idea, but we got to figure out how we use it effectively. And that
So,
to
so
me is, I
Marv,
hope, yeah.
so Marv, that being said, and maybe I'll pose this to Dr. Counts and Dr. Thayer, is that, it's there's just all this talk about doing RCTs when there's so many variables in this bundle that we're talking
Yeah.
about. And now many of us now are doing things even differently. We're starting AP. People are doing double sequential. People are removing epi. People are adding esmolol, et cetera, et cetera. So maybe I'll ask, and Dr. Snyder, Dr. Sayer, Dr. Count, you can take this.
Excellent.
But how do we answer this question really effectively when there's so many variables involved in cardiac arrest and every system is indeed different? So for example, I saw your bystander CPR rate is significantly higher than the rest of the country. Obviously, you guys have been doing that for a long time. How do we answer this question?
Well, I think because of the heterogeneity of these patients, it's one of the key reasons why randomized trials are so useful, and because you're really going to allow the roll of the dice to ensure that the two groups are comparable, hoping that that actually works, of course, which usually it does. Because observational studies end up, as Bonnie learned, you just don't know all the unmeasured confounders and what they could be. And you make choices that are maybe not even explicit about sort of things that bias the answer. One thing that gives us reassurance, and I was trying to get a link to drop into the chat, is an much smaller observational study that occurred around the same time in suburban Bellevue, Washington, and in which a very sophisticated group of paramedics used the Philips NM3 device that they no longer make to actually measure pressure and tidal volume. And this was mostly in a post-ROS cohort. We had very few cases with ongoing CPR. But they changed from a large bag to a small bag. And the actual tidal volume delivered was essentially the same with the two bag sizes. And that's because the crews are trained to target an end tidal CO2 level. So
Right.
they are compensating if there is any actual device delivery difference, they're compensating. I also think a key difference here, and I see Mike Helbach is on, is sort of how the crews were trained to ventilate with the large bag. And I don't know, Mike, you want to comment on that?
Sure, Dr. Sayer, thank you. That is actually one of the biggest drivers, I think, that we instituted when we developed the high performance CPR program. We were clearly overventilating from what we thought at the time by standard adult bag, and we were, as we've all done for decades, we were using every cc of volume out of that bag. We pulled back to that and went to a 350 to 500 mil uh, volume from the bag, and then taught, as you know, Dr. Sayer, all 4,000 providers in Seattle-King County. And I think this was one of the biggest issues we've been driving for years, is that is the one piece of data that we're missing in the real application of a cardiac arrest scenario. We can get it in training because we have devices that can measure that. But that one piece of data from the actual field performance is what we've been striving to get. And I really appreciate this conversation, the study, Dr. Snyder and your team, and certainly Counts and Dr. Sayer and everybody else, because I think this has brought this to the front of the table. And I think all of our conversations and practice need to really figure out the best way to pull this off. Michael?
Great comment. The follow-up I want to make, because obviously there are people doing things differently, and this concept of minute ventilation, and also aligning that with the amount of positive pressure we're giving these patients in cardiac arrest. So many people are doing one breath every 6 seconds at that volume. What we decided to do is to go one breath every 10 seconds with a larger tidal volume, effectively keeping the minute ventilation the same, but trying to minimize the amount of positive pressure that these patients are getting, so that we can not only get down to the deeper zones of the lung, but also try to ensure that we're getting appropriate blood flow across the lung. I wonder if anyone has any comments on that. I know I don't see Dr. Pepe on the call today, but did anyone and the folks in Polk County have been doing it for years. We've adopted that as well, and our numbers, which I posted on LinkedIn the other day, are the best they've ever been. But again, observational. We haven't published anything. It wasn't planned on. That's just our CARES data that I put up on the internet. And I'm wondering, does anyone have any comments on that aspect of it? Larger tidal volume, fewer breaths or fewer ventilations per minute. Marv says, do you actually think that the 10 larger volume breaths are not doing it with increased pressure? Again, that's a great question. I don't know the answer to that. I will also tell you that what's also on the market now are these ventilators, right? So we are now starting in actually in October, we're trying to train on the T1, or we're giving our EMS captains the T1 ventilators, and that ventilator does have a CPR mode. Again, we have no experience with it, and I follow along on the literature to see and folks on the ground who are using it with success. But I think that's also a future of airway ventilation, because as Marv mentioned, the human factor here is something that we have to account for, and I don't think it's very easy to do. It's not easy to do. Anybody else have any comments? Bob, you want to? Bob Page, go ahead and unmute your microphone. We'd love to hear from you.
Yeah, I was just thinking and looking at almost all the studies that I've seen done out there, there's one big gap, and that's been no one's measured a tidal volume. So whether it's an endotracheal tube or an iGel or a BVM that's small, BVM that's big, or even a device that restricts the flow, we still don't know the tidal volume we're delivering. And so it just seems to me like if we have a way to measure the tidal volume and get feedback, like the EOLIFEs that are out there, if we have a way to ventilate and get feedback right there at the point of doing it, then that could optimize ventilation to what the normal parameters are, is what I'm trying to say. Who knows what they are? We have 6 to 8 milligrams per kilogram ideal body weight to go by, but that could be as much as 400 for some, as much as 600 or 800 for people like 6'5" or something like that. And so there is a great variability, true, but I think if we can adequately measure the tidal volume that we're delivering to the patient, what goes in and what comes back out, that would be a great thing. And also remember, end-tidal CO2 requires an end-tidal volume. And so if it's dead space, it's just gonna read what comes back and forth, more dead space than alveolar volume that actually comes out. And so, yeah, first of all, I love the study you guys did. That's great that we need to look at that. But then again, we need to see what volume was delivered by the small bag versus what delivered by the large bag. Either way,
that's right.
It's working that.
And they are doing that. Bonnie, you want to make a comment? Go ahead.
Yeah, just calling back to sort of similar to my previous comment, but just knowing that measurement of tidal volume is not, widely available, that Zoll has it available. Stryker does not yet have it available, and obviously equipment changes are a huge undertaking for many departments. I think just going back to your point about the height is an interesting potential kind of meet in the middle while we figure out more of this data, just knowing that a small bag is unlikely to ventilate a very tall person correctly, and thinking sort of similar to how we treat children based off of height, like, is there a world in which there is a ventilation Broslow tape for adults that helps guide what choice of bag may be better? Or even within that, like how one-handed versus two-handed might affect your tidal volumes, having a goal kind of tidal volume in mind based off of the patient height.
Right, and when they hooks them up to a ventilator, the ventilator initial settings are set based on the patient's, the chart on how big they are and such like that. And so if we could set the ventilation monitor at the same thing, this person is for this size and this weight, this is what it should be for a tidal volume, and give them feedback, it seemed like that would be the happy medium till we figure all this out.
Excellent. Yeah, and again, that's why I'm looking forward to seeing what the folks in Seattle are doing, and the whole ventilator movement. But I also wanted to ask question of PEEP valve, and I'm seeing in the commentary that Dr. Count saying that you guys are not using PEEP. It's a huge question. I get it all the time. I would love to hear some comments on why no PEEP, and for those who are using PEEP, why PEEP? How come we haven't solved that one yet? Anybody want to take that?
To clarify, we carry PEEP, but it's not standard practice for cardiac arrest patients. It's applied to a different population. So we track if it's used, and it's just not used in this cohort.
The
Right.
overall physiologic logic behind not applying PEEP during cardiac arrest at Seattle is the concern that we already have about intrathoracic pressure and sort of all the negative downstream effects that I mentioned for that, and whether or not PEEP in cardiac arrest could adversely contribute to that when we know that in cardiac arrest, our cardiac output is, 10 to at max 25% of what is physiologic. And so that is the concern there. There are potential patients within this cohort who may have had a PEEP valve applied while they had a pulse, and either rearrested or arrested later that may be affecting it. But PEEP is not recommended because of the concerns for intrathoracic pressure.
Right. And the folks who don't use PEEP, that's exactly what they mentioned. And the folks who do use PEEP are saying that they're doing it for recruitment and they're doing it for flow across the lung. But it's a fascinating discussion that here we are. And if we had to flip a coin, it would be a 50-50, I guess, across the country. Let's bring in Lou Steinberg, West Palm Beach.
I was just thinking with the PEEP that impedance threshold device, everything we do is geared towards negative pressure. We know the recoil is important with that to enhance blood flow back to the heart. So PEEP would seem to be the opposite of what we're really trying to do. Just one other further unrelated note is the problem with cardiac arrest in the field is they're like snowflakes. No two are really alike. And we could look at that mean or average line or whatever, but you had outliers in different things. We'll never know how long someone's been down before we get there until it's ironic. My dog is microchipped. When we microchip people, we might know, but how long have they been down? How long without CPR till that first compression? Even a witnessed arrest, we don't know how long it took the person to fumble around, figure out what to do, how to call. So that's always a confounder that we may never know how to factor that in.
Yeah. All right. So
I think
as we conclude, oh, go ahead, Bonnie. Go ahead. You can respond to that.
that is my biggest takeaway from doing thousands of hours on this research project is that cardiac arrest is so complex. We actually have very limited high quality data. We have a lot of theories about the physiology of cardiac arrest and really very few facts. And so I think we're all just trying to make the best decisions for our patients based off of limited data. And this is just sort of contributing to making it even more complex.
So I'm going to bring in Tanner, and then Bonnie, I'm going to give you the last word at the end so you can give us recommendations on what to do next. But Tanner, you're our research brain here. So I'll throw to you and to Catherine. What do we have to do here to really answer these questions effectively? I mean, we've heard what is ongoing. We've heard what Dr. Sayer thought we have to do. What are your thoughts, you, and I'll throw it to Catherine as well, that the people on this call could start to get a better feeling about what they're doing at their own jurisdiction?
Yeah, I think one thing that I was thinking about while listening to what everyone was saying, just about, I mean, the experimental evidence that suggests that hyperventilation is harmful for out-of-hospital cardiac arrest isn't the strongest to begin with. So the in those original pig studies that claim that hyperventilation is harmful, they were using ventilatory rates of 30. They were using super physiologic volumes. They were really pushing these animals to their extremes. And that's what they had to do to validate the principle that these increasing intrathoracic pressure decreases blood flow and worsens outcomes. But I think the clinical data out there that shows that hyperventilation is harmful, which I think many in EMS have really taken as a basic principle and is taught in many paramedic classes across the country. the clinical data really isn't there for that claim, and it's based primarily on laboratory data, again, based on my read of the literature. So I think we are moving in the right direction, right? Getting kind of the ability to measure these kind of personalized values for our patients, being able to measure actual delivered tidal volumes. When our group had presented previously on end tidal CO2 values from the ESO data set, we discussed using waveform morphology to be able to determine whether we're hyperinflating or hypoinflating the lung. That might be a future direction as well. But I think definitely kind of moving ventilation toward a personalized intervention, and being able to measure precisely what we're delivering to our patients in terms of volume and pressure and rate. I think that's going to be extremely important moving forward.
And then before I go to Catherine, can we all also agree that these studies have to be done in the EMS environment, and perhaps we shouldn't be taking our cues from the in-hospital environment? I do know now there's a study I just heard about this week called OptiVent, where they're trying to look at what is the optimal ventilation strategy for cardiac arrest in pediatric patients, after the whole debacle that I've been very vocal about in pediatrics, where they used the one observational study to change practice. It looks like now they're going to go and do a very large study, again, in hospital. I would like to see that, people treat EMS as a different entity and not bundle it all together with the ICU. So, but with that being said, Dr. Counts, any follow-up or feedback on what Tanner just mentioned, and what are your thoughts?
So as a reminder to folks, to do a high quality cardiac arrest randomized control trial, it's $5 million from the NIH. Cardiac arrest is not a single body part disease, so we struggle to get it funded through the NIH. That's kind of part of what's going on here. Is it's just nobody wants to fund it. There's not any going on right now funded through the NIH, except for the PE part. As far as I'll let Bonnie to give her opinion on this, but Seattle Fire hasn't changed its practice. As a reminder, we published this paper and then we didn't take away the small bags. So that should speak volumes to anyone considering changing their practice because of this paper. Because the reality is we don't understand the why, and we don't understand the confounders because it's not a randomized control trial. We're a 1,000-person organization. You heard Mike Helbach talk about training the 4,000 providers across the entire county. To decide to make a change in clinical practice due to a single observational study is inappropriate in our mind. And so we're in the wait and see. And before we turn the battleship, we're going to get more data, which is why we're doing this randomized control trial between IGEL and BVM and measuring more data than we were during this observational study. Bonnie?
Right. Yeah, Bonnie, but I'm going to give you the last word, but Catherine, that's a great comment. And what I think is happening, what I see happening around the country is that everyone's doing their own little experiment, right? Because everyone's community is different. We're all ALS. Some people have a tiered system. It's all over the place. And so I think that we all have to continue to learn from each other, keep up on the data, understand what's really going on out there, to ultimately try to figure out what we need to do as medical directors for our own systems. And I think the only way that, at least the best way I could see it going now, is by looking at our care's outputs, period. I think all of us need to know every single patient, you have to be able to break down your care's data and know exactly what's going on at your system. And if you're on the lower aspect of outcomes in the country, then you got to make changes. And if you're on the higher, end of that country data set, then maybe we ought to have more conversations to try and figure out what exactly is going on. But at the end of the day, we do need these really well done studies to try to answer some of these questions so that the other people can follow along. But with that being said, Bonnie, this was an amazing presentation. I would love to give you the last word. You put a lot of work into this. You brought a lot of people on here today. We're very interested in the many thousands who will watch this presentation afterwards. What would you recommend to the person who's an EMS chief, a medical director, sitting out there listening to this, who's heard all these people talking and saying at the end of the day, I still don't know what to do? What would you recommend to them? And give us your final word.
Yeah, absolutely. Again, thank you so much for having me and for everyone coming on and engaging in so much fun conversation about all this uncertainty. I would just reiterate that cardiac arrest is such a complex derangement of physiology We know there is profound metabolic acidosis that happens, that everything about your respiratory and cardiac mechanics is different than when you are alive, and that perhaps everything we know about ventilation is built on this like house of cards, and who knows whether like the hyperventilation and a compensatory respiratory alkalosis could actually be helpful in this setting. There's just so many unknowns, and I would just recommend to focus on the things that we know work, training your public to perform bystander CPR, public access of AEDs, early defibrillation, high quality compressions, and a supraglottic or endotracheal airway management within title. If you have the resources to provide more real-time feedback using a manometer or tidal volume or impedance or SpO2, like that is great. But again, not necessarily like a generalizable recommendation. So I think just continuing to focus on the basics while we continue to get more information about this is really kind of all that I can take away from all of this uncertainty.
Well, before I let everyone go, I'm going to throw a wrench in at the very end because you just made me think of it as you're making your comment. So, I got into a little bit of a Twitter spat with some guy from the Netherlands, and he's like, "You Americans don't know what you're doing." I said, "All right, big shot." So I said, "Send me your data," and he did. And so you could see here that if we just go down to neuro intact survival, I mean, they're almost quadruple the United States. Now, there are many reasons of that, and a lot of the reasons, come down to their bystander CPR. A lot of the reasons come down to the AED prior to EMS, first defib by bystander. And so there's a lot of other variables that are happening that also may have a bigger impact than even the things we're talking about. So that's what I love about, and by the way, look at what's happening in Saudi Arabia. So obviously there's a clear difference wherever you live in this world. So, but that being said, that's why I love this profession. I love the science of cardiac arrest, and to all of you on the call who are scientists, thank you for your contribution, Dr. Snyder. Thank you for coming on all the way from Paris. We appreciate you. And from Florida, myself, Tanner Smita, we thank you guys. We will put this on YouTube very shortly, and please share with your other folks. So thank you so much, and I'll have a great day.
Thank you, everyone.
Thanks, Bonnie.